Hi, this talk is going to be looking at how we assess functional capacity in the preoperative assessment unit. So what we're really looking at here is the combination of physical fitness and surgical stress and how these two interact with each other. Physical fitness is also considered in terms of, maybe discussed in terms of functional capacity and also exercise tolerance. So let's start by looking at what happens when we exercise. Exercise requires energy for the muscles to work. The energy that's used is in the form of adenosine triphosphate, or ATP. This is produced by metabolism within the body. Metabolism uses oxygen and produces CO2. Underpinning this process, therefore, are the lungs, which take in oxygen and excrete CO2, and the heart and cardiovascular system, which transport the substrates and gases to and from the metabolizing tissues and muscles. The harder you exercise, the more energy you need, which means more ATP and more metabolism. And this means that there is more work for the heart and the vascular system and the lungs. This would explain why we tend to get short of breath with increasing levels of exertion. Physically fit people will tolerate higher levels of exertion and will get less short of breath. How does this relate to surgical stress? During an operation, tissues are damaged, and tissue damage elicits a significant number of responses within the body, such as inflammatory changes, coagulatory changes, immunological changes, and various processes leading to tissue repair. All of these require energy, which is provided in the form of ATP. So as with exercise, this is formed by an increase in metabolism. So oxygen is required, carbon dioxide is generated, and therefore the lungs, the heart and cardiovascular system have to work harder to cope. The magnitude of the surgery will influence this metabolic surge. Large intra-abdominal procedures produce much more tissue damage and result in greater changes and therefore require more energy for the patient to recover appropriately than more superficial or limited procedures. So if unfit patients undergo major surgery, their ability to respond to these increased metabolic demands may be significantly impaired and stressed to beyond breaking point. Failure to increase the availability of energy might lead to major serious complications such as wound failures, for example breakdown, wound dehiscence or infections, circulatory failure, renal failure, respiratory failure or gastrointestinal failure. It's for this reason that we put so much emphasis on the importance of assessing functional capacity prior to surgery, and that's why it would be the first section of our preoperative assessment. So if we look at our documentation, the first section has, does the patient get short of breath or chest pain, and then there are five different levels of physical exertion at which those symptoms may or may not occur. You'll notice that in brackets there is the term 1 MET, 3 METs, 4 METs, etc. And MET stands for metabolic equivalent, and this is a measure of energy consumption. 1 MET would correspond to the energy being consumed by an average adult whilst sitting at rest doing nothing. And corresponding METs go up according to the physical exertion that the patient is undergoing and how much energy that would require them to consume. What we're looking to assess is what is the best level that the patient can achieve. There's a section beside this for you to write comments, and this should always be filled in. It's important to know what it is that's limiting the patient to this level of exertion. What the symptoms are these symptoms old or new? Are they stable or getting worse? Stability should be assessed in terms of both frequency and also severity. What I'd like to do is look at some made-up example patients and just try and demonstrate how getting a clear documentation of the level of exercise capacity the patient has, and also the importance of some added comments which will give some more information about that level of exercise. So first of all, this is Jim. He's a young lad who's coming in for a hernia repair. He plays football every week and gets a bit short of breath when he's running up and down the wing, but has no other symptoms, no chest pain or palpitations. So clearly documenting his would be a tick in all of the no's except for strenuous activity, and then quantifying that in the comments section. So what about this guy? This is Bob. He's coming in for a total knee replacement. He uses a wheelchair whenever he goes out because his knees are so bad, but in the house he generally potters around. He is able to do a bit of light housework, and as such never gets any significant levels of shortness of breath. He can lie down flat without any trouble, and he never gets chest pain. However, the important thing here is that he never really stresses himself beyond what he does in the house. So it's important that whilst we've documented the absence of symptoms at these levels of exertion, that we quantify the fact that record the fact that he uses a wheelchair whenever he goes out, which is when he would possibly have had the opportunity to exert himself at higher levels. This is Jim. He's a 73-year-old who's coming in for a lat chole. He uses a walking stick because of an old injury to his leg, which causes him to be a bit unstable. He's had ischemic heart disease for many years, and he still gets chest pain when going up an incline or up the stairs. He's had this for many years. It occurs only with exertion. It's self-limiting, always goes away if he stops or takes his GTN, and it's not occurring any more often than it used to, and the severity of it is very much stable. Now Mark here is a busy guy, runs his own business, and has noticed that he's had a bit of chest pain recently when rushing, and this is something that's new. It seems to be occurring perhaps more often than it was 3 or 4 months ago, and is becoming more significant. Now, in difference to Joe, Mark gets chest pain, but it's at high levels of exertion similar to Joe. Chest pain would always be suspicious and requires further investigation, whereas Joe's symptoms of shortness of breath at high levels of exertion are appropriate and of no concern. So in summary, assessing functional capacity or exercise tolerance is a vitally important part of the anaesthetic assessment. It gives an indication of patients' ability to cope with differing grades of surgery. Patients who are undergoing major surgery need to be fairly fit to cope with the stresses that this elicits. Because the heart and lungs are intimately involved in the metabolic cascade occurring during increasing exercise, symptoms which may be limiting exercise can give us vitally important information about the stability and severity of underlying cardiovascular or respiratory disease. It's therefore vitally important to document what is limiting the patient's exercise, for example, shortness of breath, chest pain, but also remember some patients' exercise is limited because their skeleton's not working for reasons such as arthritis. So there we are. Thank you very much for taking the time to listen to this. I hope it's been of use. If there are any questions or queries, please do not hesitate to get in touch with me. Thanks very much.